Good evening, everyone. Welcome to tonight's meeting of the Health and Social Care Scrutiny Review Group. Excuse me. Just do the admin stuff first. This meeting will be live streamed to the public. Recording of the meeting will be available on the website within 24 hours of the meeting. Any remote participants joining using Teams, please could you use the hands up icon to indicate you want to ask a question or make a comment, and turn your camera microphone on when speaking and off when finished. For those of you in the room, please remember to switch your microphone on when speaking and off when you've finished speaking, and speak directly into the microphone. With in-person attendees, please switch off mobile phones or place on silent mode. Okay, apologies for absence.
Apologies from Councillor M. Hussain, Councillor Gallagher, who Councillor Wynne is substituting for, and Stephanie Powell from Health Watch.
Thank you. Minutes of the last meeting, 24th October 2023. Trust everyone who was there has had a chance to. Are those minutes okay? Thank you. Any disclosures of interest?
None, Chair.
Any urgent business?
Again, none, Chair.
Any references from committees or other bodies?
None, Chair.
The only thing that I have to report on is if you haven't already realised that the reconstituted JHOS will be meeting for the first time next Monday, and those papers, gender papers, are on the website if you want to have a look at those. JHOS is, for those who don't know, JHOS is the equivalent body, Health and Social Care Review body for the whole of the BLMK. Okay, on to the first item. Item number 7, primary care access in Luton. Who will be? Hello, Amanda. Is your microphone muted? Can you hear us, Amanda? Can I ask if any of the other remote participants can hear us? Can you hear us, Michelle?
Yes, I can hear you, thanks.
Thank you. Is there any way of sending Amanda a message? Can we send that?
I put a message on the chat to her, asking if she can hear you.
Thank you. Hello, Amanda.
Hello, good evening. Sorry, I had to dial out and join again. I had some technical issues.
Okay, yeah, please go ahead.
Am I being asked to present the paper? Sorry.
I believe so, yes.
Okay, sorry, thank you. Okay, so if I draw attention to the significant items that we've covered in the paper that we've presented to the committee, what we've attempted to demonstrate is to show the transformation that we're undertaking with primary care and general practice in Luton and across BLMK. And there's two significant national reports that we're drawing on to provide the framework for this transformation. The first is the Fuller Stocktake that was published in May 2022 that talked about the requirement to support primary care transformation in the context of the whole system. And the second report is the NHS England published report in May this year, which talked about how we can recover access to primary care for our residents and our population. We're using these two reports to provide a framework to support our system transformation and support the specific work that our practices and primary care are doing to provide access to the population. As I've said in the report, the delivery plan for recovering access talks about a modern general practice access model. And we've asked each of the practices in Luton to set out a plan how over the coming weeks and months they will transition from the traditional model to the modern general practice access model and ensure that is how primary care general practice deals with calls in a timely manner. Rather than asking residents to call back, it will be indicated on their first call how they will be dealt with. And that can be signposting, that could be seeing the patient by the appropriate means on that day, or by directing them to a different service provider. But essentially, it is managing that resident's need on that day. To support this, we're increasing the coverage of cloud-based telephony, which is a more sophisticated telephone system, which allows us to track the incoming demand and ensure that we can support capacity in the appropriate way to manage those calls. We've now had all of those transition plans from our practices in Luton, and we're working through the plans that they've set out and how we can support them to deliver what they've described. Key to delivering general practice access and supporting our residents is how we support our population collectively and with our stakeholders to engage in prevention and self-care. We know that in the region of 20% of the population who access an appointment in general practice could have been supported differently. And if we can manage those residents and use different parts of the system to support those residents, we can ensure that general practice is reserved for the population with the most complex needs who really require that multidisciplinary approach offered by the general practice teams. So we need to increasingly be clear about what the alternatives are for our population and help them navigate through those different offers. What we've also demonstrated in the paper is that despite the constraints that our practice teams continue to offer, we continually see growth in the number of appointments offered by general practice. We've given you a snapshot in the paper which demonstrates that for the 3 months, July, August and September this year, compared to the same 3 months last year, the practice teams have offered more appointments, and that's a recurrent picture. We're seeing growth in the number of appointments offered by practices. But the work that we are doing is to try and bring a sustainable approach to the system by supporting our residents through the offers available to them in a different way. What the data that we've presented in the paper also shows is that the teams in general practice are changing. General practice is a multidisciplinary team. It's led by a GP, by a medical GP, but there is a range of professionals now working alongside in the community, and that our residents will see the professional that is more suited to their need. Some of the examples of the professionals working in general practice are physios, are nurses, are paramedics, are what we call social prescribers, health coaches and care coordinators. And all of these people can support residents with the needs as they present. We see a significant number of appointments delivered face-to-face in Luton, higher than the national average. And the work that we're doing to understand how we manage that demand on the same day will help us understand how we can book patients' appointments routine in advance, but how we can provide an appropriate number of same-day appointments where that's needed to support people with an acute or episodic need. I'll stop there and I'll happily take any questions from any member of the committee.
Thank you, Amanda. Okay, vote is open. Does anyone have any questions? Councillor Fright.
Yes, thank you, Chair. Just one question. On page 15.11, it says practice has been asked to set out their plan by the 17th of November. Has that deadline been met?
Yes, it has been met. All of the practices in Luton have submitted as of Friday the plans for that transition to modern general practice access. And as ICB, we're working with our established access clinical leads to review those plans and to understand what support we can give those practices and the transition plan that those practices have set out. The delivery plan for recovering access to general practice and primary care is a 2-year plan. So it was launched in May this year and it's expected to go through to May 2025. So those practice plans will be staggered over the month that follow through to that March 2025 deadline. And at a future committee, we can clearly set out those plans and how each of our practices are progressing.
Thank you.
Councillor Ali.
Hi Amanda, thank you for your report. It's good to see the progress. My question is more specifically about so the GP surgery in my ward, Hightown, was shut over the summer. I understand that we sort of own the land or the building that it goes on, and there are lots of discussions about continuing to use it for access to primary care. Maybe not GP surgeries, but some of the other, like you said, you can see paramedics and things like that. Is there any progress on that, and how that? Is there anything going on there? Because that's a few thousand people that were using that, and that could be used for something else if we own the building. Thanks.
Thank you. I'm afraid I don't have the detail to specifically answer that, but I'm happy to take that action away, seek the detail and respond to you outside of the committee if that's acceptable.
Yes, thank you.
Thank you.
Thank you. Councillor Wynne.
Thank you. I was going to give way to the permanent members of the committee, but anyway, okay. Speaking as somebody coming in from the outside rather than a permanent member of this review group, a specific question first of all for you, Amanda. All of these GPs moving to the new approach that you've suggested, it has implications of new telephone systems, new IT support requirements, training of all the existing staff in the GPs, maybe ought to be also considering what use could be made of artificial intelligence to try and get this more precisely done. Are all the GPs getting the money to do all this?
So if I take telephony first, so the delivery plan for recovering access comes with additional funding to support practices to transition to new cloud-based telephony, and we're just working that through. We have a number of practices already on those systems, and with the NHS England report for recovering access to primary care, there is additional funding being made available for practices to move from their analogue systems to the cloud-based systems, which are more sophisticated and allow practices to really see the demand that's coming in, and has different functionality. So yes, cloud-based telephony is being progressed, and that comes with funding. You talked about training for staff. One of the crucial elements of delivering modern general practice access is care navigation, and is to support the receptionist and administrative teams to support patients and navigate patients through the system as I've described. So we are providing a continual offer of care navigation training to support those practice staff. And it's really important that we do that. We've historically seen high turnover amongst those staff groups in general practice, and it's important that we recognise how valuable they are, and support them to develop into those roles for care navigation, and make those roles more appealing in the future. You talked about IT. There is significant investment in IT and how we support through our digital strategy, the integration and interoperability of our IT systems, so that between providers, those IT systems talk to each other. So yes, again, that investment and that support work is being done developmentally with the practices. So this modern general practice access is absolutely not in isolation. It does require support and is receiving support for all the factors that you've mentioned.
I'm just going to do a follow-up, and then I'll see for the moment at least. My experience with my own general practice is that the only progress that's been made over the last year is that you used to book an appointment with the GP if there was one available, and then you'd go and see the GP. What happens now is that if you can convince the receptionist, they will then ask the GP to phone you to see whether or not you can have an appointment. So to me, what I've seen in the last year from a personal point of view, not across the board, I'm just talking purely personally, is backward. The thing you're talking about IT worries me, because as somebody who unfortunately fits into your category as having complex health conditions, it seems to me that every single time I go to have any form of treatment, there is a total lack of joined up data within the NHS, as far as I can see. I end up, for example, having to give my prescriptions list, my prescription medications list, to every health professional I ever see. So I know it might sound, especially as somebody who isn't a permanent member of this group, but I'm afraid that the words look good, and I appreciate the objectives that you're trying to get to, but it's nothing like the reality I see, I'm afraid.
Thank you for that. And what you've described is consistent with a number of our residents in Luton, in Bedfordshire, Luton and Milton Keynes as a whole. We know that the experience of our residents getting through on the telephone and being able to make an appointment requires significant improvement. We do know that once residents see a professional in the practice, their experience is good. So once you get in front of a professional, that people feel satisfied and feel like progress is being made. The work that we're doing in Luton to support integrated neighbourhood working, so bringing all of the teams across our stakeholders together to coordinate care around the population, around individual people, should start to bring improvements from what you describe as having to repeat yourself and having to tell your story multiple times. We know that that is frustrating for residents, and it's also not helpful. You need that consistency and continuity of care. As I've described, we recognise that experience needs improvement. The plans that we set out are 1 to 2 year plans. And in the meantime, we need to work with stakeholders and with our residents to communicate those plans and to bring about the changes over the coming weeks and months that we can. We appreciate it's frustrating when people can't get through on the telephone and make the appointments that they need. But hopefully, when we work with the practices on the plans that they've set out, the changes will hopefully be realised for our population over the coming weeks and months.
Chair, I would like to come back with additional questions, but I'm going to cede to my colleague over.
Thank you. Yeah, Councillor Nissa.
Thank you, Amanda. So, I mean, I just going back to about the modern general, model. You're talking about the model, modern general practice model. So I'm still want to understand that, when usually there was the receptionist who used to take the call. So does that mean at the moment there won't be a person who will be taking the call, or and if the problem, I'm just echoing what the previous gentleman said, that we do face these problems every day. People in our community, English is not their first language. So they are afraid to go and make an appointment or, waiting on the call. So they do walk in to express themselves for an appointment. And I want to know also that, once you navigate the specialist, if someone goes with a problem, they need they need to see a physio. So how would they know? Will someone reply them the day that this will be referred to a specialist? So they will be, they can, stay in peace that something is going to happen. And other question is about, you said this is a 2 years plan system. So is that what we just a trial, and after 2 years, what we're going to see? Thank you.
Thank you for your questions. So to provide you some assurance, absolutely this will be a mixture of patients being able to attend the practice or to telephone or to use online to request services online. There will still be people responding to these requests. This isn't to take away the receptionist role, but it is to provide additional training and support to those receptionist roles to allow them to support residents and do that care navigation, which is really central to this. And hopefully that will bring about greater job satisfaction for those receptionists as well, in it being able to support residents more clearly. Your second question was about if a patient is referred to a specialist. So we do know that there needs to be better communication with residents when they are referred to specialists, and whether that is communication from the practice team or from secondary care. And we're putting a lot of energy and a lot of time into thinking about how primary care and secondary care can work better together to improve the experience of our residents. We do know that sometimes when residents are referred to secondary care, there can be a lack of communication about what happens next. So we're working with our hospital colleagues to ensure that we improve that. Because we also know that if residents don't hear about the next steps in their care, they default to their practice, which is absolutely understandable. And that creates footfall into general practice that we can avoid. So we are trying to ensure that patients understand what is happening to them and clearly communicated by providers at each step of the pathway. Your third question, apologies, I did write something down, but I've lost track of your third question. Could you just refresh my mind?
Yeah, it's about the 2 years plan. You said this is the 2 years plan system, and just want to know what's going to happen next.
So it's a 2-year plan. It recognises that there is significant infrastructure change that needs to happen, that to reorganise professionals to work in different ways, to work as integrated neighbourhood and multidisciplinary teams to support individual practices to change from their traditional models to modern general practice models will take some time. All of the training that I've talked about, the IT development, the telephone development, takes time. So that's why it's a 2-year plan, but it is designed to be a sustainable plan. So it isn't a pilot, it isn't a test. When we implement these changes, we'll continually evaluate them, but the intention is that some practices will implement some of this quicker than 2 years, and some will need more support along the way, but it is designed to be sustainable change. But the 2-year is just recognising the journey time to get there.
Thank you. I just want to make another a comment, actually. When patient goes to the surgery and if they don't see a well-trained receptionist with, happy face, that's the problem. We have so many, surgeries. So please make sure that, extra training has given to them, because patient when see a happy face and talking with them nicely, they feel better. So that's very important. And please, can you note that one as well? Thank you.
Thank you. That's a really helpful comment, and the investment into care navigation training and other forms of training for those front of house staff is absolutely central to our plan. It's really important for our residents, but it's really important to retain and support the workforce as well.
Thank you. Mark?
Thank you, Chair. Hi, Amanda. I've just got a couple of quick questions and similar sort of topic, really. One is that you mentioned the increased number of appointments that are being offered at the moment. I just wondered if there were any sort of themes behind what those appointments link to, and also if there's any work going into repeat appointments and how that might link to a more preventative approach as you move forward.
So I haven't got to hand, Mark. Thanks for the questions. Detail tonight in terms of what those increased appointments are, but using population health management in the future, that should inform how we work as neighbourhood teams and how we support our population in a different way. And absolutely, if we move to proactive care for some of our residents, that should help us to reduce the number of appointments that they have. So actually, if you do a longer appointment with a resident and really manage their care plan and support them with their own goals, then that should reduce the number of appointments, the repeat appointments that they would need. It really is about mobilising and empowering residents' own resources to manage their conditions.
Sorry, just really a quick follow-up, and I'm not sure if it's here we would take, but Amanda, I do think that's a piece of work it would be really interesting to understand if that information is to hand. So what the things are behind the appointments potentially, and the work we're doing around repeat appointments, and again, sort of that prevention agenda, because we all play a part in that, don't we? That's the thing, and that's what we'd like to get across. So whether that's an item that comes to scrutiny or goes to health and wellbeing first, we just ask if we pick that up in the notes so we can take that away.
Yeah, I think that's a really good action for us to work on, Mark, and one that we can do from the information that we hold in our systems.
Thank you. Just to follow up on that, Amanda, you also spoke about residents turning up at practices when there's a problem with their appointment or a problem with their care is in a similar sort of ways. Is there information collected about that?
Yeah, so absolutely. As I've said in the report, we estimate that in the region of 20% of patients who contact their practice or occupy an appointment could have been managed in a different way. And a significant amount of that relates to patients who are unclear what is happening to them when they've been referred to secondary care. So we have established a regular dialogue between primary and secondary care clinicians. They're meeting monthly to discuss those operational challenges and improve how they can work together for our residents. We absolutely understand that if residents are unclear what is happening to them on a waiting list, or if they're unclear about the next step in their care, they will default to their practice team because they are often the first point of contact. So we're trying to establish clear communication routes from secondary care to residents so that patients understand where they are on a waiting list or what the next step in their care is.
Thank you. Councillor Wynne?
Thank you, Chair. Yes. Looking through the report, there are references also to pharmacists and the role that pharmacists take. My experience, at least locally here in Luton, is that the majority of the pharmacists are not actually trained and able to prescribe. So very often going to see a pharmacist is not a satisfactory route. The other question really associated with that is, apart from training to be able to prescribe, as my niece as a pharmacist has done, what training is being given for diagnostics, people skills, because again, we go back to the issue of language and manner. My personal experience is that not all pharmacists are necessarily as good at interpersonal skills as some of the medical practitioners. And the final bit, if I can add that in as an extra question, is your report on page 19, Appendix B, includes dentists. We've heard nothing in the presentation of this report concerning dentists, which I consider in Luton to be a complete disaster area. My own dental practice, fortunately, I'm in a position where it didn't worry me too much, but they arbitrarily had taken me away from being an NHS patient, and I'm now paying privately. It doesn't worry me because I can afford it, but it would worry many of my residents. And I think that the cavalier manner and the lack of service of dentistry is a major issue. And it doesn't really seem to be covered by your access model. And certainly my dentist doesn't seem to actually communicate at all.
Thank you. If I take your question initially about pharmacists and community pharmacy, so we have a number of pieces of work aimed at increasing and supporting the role of pharmacists, as you've described. Pharmacists are being supported to be independent prescribers, and in the future, all community pharmacies will be trained as independent prescribers. You've talked about the skills about front of house. I mean, part of the work that we're trying to do is talk collectively about primary care and how we bring neighbourhood working together, which is about how practices work with their local pharmacists, how they work with their local opticians, and how they work with their dentists. And working in that way collectively can support each other's understanding of population needs and how we support residents. Your questions about dentists, I don't know if you are aware, with effect from April this year, the ICB took on the commissioning of dentist, pharmacy and opticians from NHS England. So this is the first year for the ICB as the commissioner of those services. Our focus currently is to stabilise those services and then to consider the transformation of those services that we need to do going forward in line with our plans for integrated primary care to support our residents. If the committee wanted a more focused report on dentistry in the future, we could provide that as an ICB.
Yes, that would be welcome, Amanda. Thank you. David, are you?
You'll be pleased. I've decided that enough's enough.
Thank you. Just got a couple of questions, Amanda. The transition plans are. Is there any desirable required level of consistency between those plans, between the practices, or are those plans tailored towards the needs of each individual practice?
So there are some features that we would expect to see some consistency in. So I mean, the model talks about how we signpost residents. So the really important thing is that practices have an understanding of their demand and their capacity on each day, so that when calls come in or residents attend, they can clearly manage that presenting need on that day. But as you say, our practices serve individual populations, so to some extent the plans will be developed to cater for the residents and their registered population. And as we're reviewing the plans, that's some of the work that we're looking at currently with our clinical leads. So it's a standardised approach, but tailored to the population that they serve.
Okay. In your review of the plans, do you have an idea of whether they're appropriate or up to standard?
So that's the work we're doing now. The deadline was Friday, so we're working through each. I'm sure you appreciate we've got 89 practices in BLMK, so we're doing that work now with a commitment to have completed that and fed back to practices by next Friday, the 1st of December. So we want a quick turnaround on this because we recognise this is really important work and we don't want to hinder or delay that important change that our practices are making. So this isn't a pass or fail approach. If a practice submits a plan and we think that sort of putting it through the sort of tests and checks and discussing it with the clinical leadership team, if we think that plan misses some aspect that's important, we will work with that practice to support their development. So we want all of our practices to transition to this new way of working. So it's about the support that we're putting in to each of those practices to get them to work in this way over the coming months. And that's the role of the ICB primary care team.
So is there a potential for, say, for if a particular practice comes up with the best plan, like the gold standard, that could feed back into other practices' transition plans?
Yeah, definitely. A really important part that we need to do as an ICB is to facilitate our practices and our primary care networks to learn and share together. So we know we've got some really good areas of practice and we need to share that and support practices who have more significant challenges, support them on that journey. We currently hold a whole range of webinars and learn and share events where we ask practices who have done some of this work already, who have done good models of care for their residents, to share that with neighbouring practices and likewise PCNs who are working collaboratively. We do very much a learn and share approach.
As you mentioned that some of this work is already started, is there any indication of how it's going? So, for example, those practices which have telephony systems, IT systems, new IT systems to assist with this, how that process is going?
I think it's fair to say that this takes some time to work through for the practice team and also for the residents. I think we've got, as I've described in the report, we've got some work to do with our residents to really communicate clearly that general practice and primary care has changed, and it will need to continue to change to support them in the way that they need to in the future. So I think we see positive moves forward. We see increases in satisfaction in some practices. We see some really other positive indicators where practices have moved to these new models, where the utilisation of 111 has reduced in hours, which is also a good indicator, because actually residents during the operational hours of their practice should ring their practice first rather than using that 111 telephony service, because actually we can navigate people better. Certainly seeing some positives, but as I've tried to capture in the report, I think we need to work really closely with our residents and with our partners to really describe the changes that we're making, because this is change, and it does represent difference for people. We know that some people prefer to be seen by a GP and prefer to be seen face to face. And whilst we would always try to accommodate those requests and needs, it's helpful if we can together explain to residents why seeing a physiotherapist or seeing a nurse may be more appropriate at this time than seeing a GP. But those messages take some time for our residents to understand and to get used to. Change takes time to embed.
And you find, as part of this process, you're finding out what the most effective way of communicating with residents are?
Sorry, I completely missed that. It sounded like you were underwater. I'm sorry, the technology sometimes.
It's just a question about as you're going through this process, you're presumably finding out what the best ways of communicating with residents are, because I know this is a question that comes up regularly during this session, is about how to communicate with our communities.
Yes, and I think there's a whole range of ways that we need to do that with our communities. Obviously, practices have patient participation groups. We need to work with our Health Watch partners. We need to work with our local authority partners. We need to work with our partners in providers as well. So I think there's a whole range of ways we need to engage with communities and with our residents around these changes that we're making. And we need to do that in written form. We need to do that directly through attending community groups to support that. So I think, that needs to be a far-reaching communication programme. It isn't one size fits all.
Okay, thank you. Does anyone have any other questions? Further questions? Okay, thank you very much, Amanda.
Thank you very much for your time.
Thank you. We move on to item, item number 8, East of England Ambulance Service Trust Performance and Progress Reports. You'd like to introduce yourself and...
Thank you very much. Good evening. My name's Simon Chase. I'm the Acting Chief Paramedic and Director of Quality for East of England Ambulance Service. I was due to be accompanied by Mark Stambridge, who's the local operation or head of clinical operations. Unfortunately, he's been called away to an incident. So I certainly do my best to cover the local elements as well in my report.
Okay, so does anyone have any questions?
Would you like to give me a quick synopsis of the report? Would that be useful?
Yes, please.
Yep.
Please do.
Okay, so thank you. So from a perspective of the trust first, so over the last, or certainly over the last sort of 3 months, the trust has spent a lot of time engaging with the leaders of the organisation. So we've held recently 2 leadership events where over 400 of our clinical and non-clinical leaders came together to look at the successes that we have achieved over the last 12 months, but also looking ahead, not only into winter, but winter and beyond, and about how we can move the trust forward. There are 3 clear strategies that we're currently undertaking. There's the clinical strategy, which is made reference in the report. And then there is also the workforce and sustainability strategy that are touched upon. We are aware as an organisation that we continue on an improvement journey. We know that in the past we've received a requires improvement inspection rating from the CQC, or the Care Quality Commission. I'm pleased to report that part of my portfolio is the monitoring and engagement with the CQC, and our trust board, the last public board earlier this month, we closed our quality improvement plan, which was the original requires improvement plan that had over 178 actions that we needed to close, and we've done 175 of those. The 3 remaining are long-term cultural actions that have been moved into the new must-do and should-do operating plan. From a workforce perspective, we have an ambitious workforce plan that we're looking to recruit just under 800 new members of staff over the next 12 months. We're currently at just over 400, and we've got over 450 in the pipeline. We appreciate that some attrition does happen when you are mass recruiting, but we remain confident that we're going to close that workforce gap in line with our strategy. On a more local note, we've had some real success around our Time to Lead programme. So this is a review of our clinical and operational directorates. If Mark was here, I would be able to introduce him as the new head of clinical operations for the Bedfordshire and Luton area. And he's now responsible for the 999 ambulance provision that covers Luton and the surrounding areas. We continue to work well with our Unscheduled Care Hub initiative. So for those of you who maybe are not aware of this, this is a collaboration that we're doing with the local ICB and ICS systems, where we're looking at where we can extract calls from our what we call our stack, which is the list of emergency calls that we receive, and we're looking how we can use and divert those prior to an ambulance dispatch to a service that is required. So a good example is if someone calls that has fallen, but there doesn't seem to be any obvious injury. When we take the triage call, we're able to view. We recently undertook a survey. So we've on our last cohort, we had 129 learners, and from that, across the trust, there was a 97% satisfaction around how they were felt to be supported within the workplace and in the training environment. And this is obviously a big step in the direction that we want to take around culture, especially with our new workforce. And finally, we're working on what's called C2 navigation. So when we respond to emergency calls, we categorize those C1, which is the most life-threatening emergency, through to C5. C2 approximately makes up around 60% of our call volume, so it's a huge amount of the calls. These would be calls that we would traditionally attend to with blue lights and sirens in ambulances or rapid response cars. And that clinical navigation tool is a national pilot where we're able to, prior to dispatch, review those calls with a senior clinician in our control room to determine if we can send those into the unscheduled care hubs. So this is something that we're currently undertaking to try and combat the increase in demand. So that's probably the general overview of what we've been doing as an organisation. More locally, Mark has highlighted to me that there's a real focus currently around improving our volunteer engagement. We know that we have some really good active schemes both within Luton and Leighton Buzzard, but we would like to increase that because we understand the value of not only utilising community first responders to provide emergency care, but also it's about the connections with community and delivery of those messages. So that's something that we're working on. We've recently expanded our collaboration with the Luton Airport Fire Service, where we now undertake a memorandum of understanding where they can render aid on behalf of the trust, and we provide the training and the support in order to do that. This is a similar system that we have at other airports across our patch, and also with the Royal Air Force responder units. So it's a model that we've been able to lift up and implement successfully. And with regards to the local issues that we're working on, we still are suffering locally with some rather protracted handover delays at hospitals. It's not just local to Luton. This is an issue that is happening nation and region wide. But the initiatives that they're undertaking locally, that Mark and the local systems, along with the Chief Operating Officer at the Luton and Dunstable, they've set a target to ensure that by Q4 and by the end of Q4, they are aiming to have no handover delays for more than 30 minutes. So this is the part of when we arrive and we can't offload. And the final part that I can touch upon is around the clinical supervision rollout. So this is something that's very close to my heart in the role that I undertake, is ensuring that we can provide a model of good clinical supervision. And this was first piloted in Suffolk and North East Essex. And due to the success, that rollout is now occurring across the patch, and Luton and Bedfordshire area are the first area to recruit all of their supervisors, which is excellent. So we'll be able to roll that model out going forward. I'm happy to stop there, and I'll certainly try and endeavour to ask any questions.
Thanks, Simon. Any questions? Sally?
Thank you. Thanks for the report. It's really just quite indicative of what the whole UK is facing and the pressures on the healthcare system in general, especially the hospital handover time. It's so counterproductive, isn't it? You've got the ambulances ready to go and then they can't offload. I have a couple of questions. So the patient-facing staff hours, why has that seen a decrease over the past few months? The stuff about sickness absence for beds in Luton, it seems that in the winter months that increases. I know generally people are more unwell over the winter months, but then having looked at the culture change and the dashboard with all the questions that people are asked and answered, I wonder if some of that is related to staff burnout over those months, because I work in the NHS and I know in the winter you've got so much more work to do and people end up going off sick because there's so much work to do and the pressures on staffing and things like that. And then what is a cultural ambassador? It says introducing cultural ambassadors. I'm not sure what that means. And finally, just looking at these results and the staff surveys, the NHS and just the healthcare is so strained anyway. And when people are stressed in their jobs, it's hard to retain them. And we're talking about recruitment, but with these sort of results, this is the type of thing that makes people want to leave their jobs. So just a little bit more about what's being done with those results. And I think that was it. Thanks.
Thank you very much for the questions. So I'll try and take them in order for you. So if we start with patient-facing staff hours, the reduction is probably twofold. So the first part is around the changes that we're making to the unscheduled care hubs, is that we've got a finite amount of staff. So even though we've got an ambitious workforce plan, we need to ensure that the abstraction rate, in order to train and be what we class as road ready, so they can start to be used outside of their training, that can have an impact on patient-facing staff hours. So when we abstract people, the numbers that you see as patient-facing staff hours is the hours we're putting out to respond to emergencies. It doesn't include the abstraction rate, and that abstraction rate will go up when we train more people. On the other side of it, we've also had to take, whilst we try and recruit externally from the ambulance service, when we've introduced the unscheduled care hubs, we've utilised a number of our staff to kickstart that recruitment. So that is also another abstraction where it's going to have an impact on patient-facing staff hours. We've just our executive leadership team day to day, we've just released a further amount of funding to look to pump prime external practitioners to come and support the unscheduled care hubs, so we can move the paramedics back onto the road. So at the moment, we are moving a finite amount of chess pieces around the board, but we understand. So I don't have the figures for beds in Luton, but looking at the trust as a wholesale, in September, the unscheduled care hubs took out around 2,500 calls from the stack. Already this month we're up to 4,000 and we've still got 10 days left. So month on month it's becoming more and more efficient. In when we receive a decision to take a call out, we took the decision to take the people off the road. So that's why you've seen a drop. That should stabilise and come back up with the recruitment pipeline. That's the ambition. I'll then take the element around retention and survey results, because it's sort of linked to patient-facing staff hours, in that 18 months ago, our attrition rate was probably up to nearly 40%. And most of those people were leaving within the first 2 years of joining us, which is not a great place to be. At the leadership day, we were able to produce a retention report that said that less than 10% of new starters in the first 2 years, cumulative, left. So we'd almost seen a 30% drop. So that was a really good marker to say that something's changed, that people are starting to stay. The second part is around our direct entries. So what this is when we attract fully qualified staff to come and work for us. We've seen we used to put on one course a year that would take 20 places. We're on our 6th course and we've had to double the capacity, because people are seeing and wanting to come and work for us, and these are qualified members of staff. So our retention numbers are actually improving across the trust. For Luton specifically, they're at markers provided with me that they're at full capacity. So there are currently no vacancies that we have in the Luton and Bedfordshire area. So they're fully established. The only one area that we need to recruit to is the Halo, which is the hospital ambulance liaison officer role. And they're actively trying to recruit to that. But that doesn't have an impact on patient-facing staff hours. As far as the sickness absence, you're quite right. We always see a spike, and there's usually 2 spikes that happen. There's one around the start of the school term in September, when people are coming off summer holidays and they return to the school, and that generally increases sickness due to children mixing and usually spreading viruses that go home. And also we have the impact around winter. One thing that we've noticed this year that's been different is that it's not in the report, but our flu vaccine uptake. So in the first 2 weeks that we launched it, we vaccinated over 22% of the workforce. And out of everyone who was offered the jab, 80% of those took those up. And that outscores by about 10% when we were introducing COVID vaccines for the first time. So the staff and we are trying to do everything we can to keep our staff healthy, but we are mindful that sickness is likely to increase over winter, and there is a direct correlation to the time that they have to spend outside a hospital, because we know that the perceived risk that we can't get to is in the community for those calls waiting. So there is a correlation. And we're trying to work with that as to understand how we can improve that. That's not an easy fix. I think until we see the handover times start to drop, we can hopefully see that morale will start to increase. And the final point, I think you mentioned, what was a cultural ambassador? So part of our cultural journey was to raise the awareness and the empowerment of a number of work plans that we were introducing. And what we were finding is that as a leader or as my heads of departments, they would often transmit information about these new initiatives and it wasn't landing. So we ran a Bright Ideas campaign, and it came out of our Freedom to Speak Up initiative, where we have Freedom to Speak Up champions. And what we were finding is that they were having a really good impact with the staff. So we took that model and we invented the cultural ambassador, and it's a multifunctional role. So part of their remit is that they will sit on, say, a disciplinary panel to provide that cultural response. They are very much in tune with that. If we're delivering any initiatives to say, if it was to a heart for us, say a disability network meeting, they would be able to coordinate that between themselves. So it's a relatively new role. We've got 7 in post at the moment, and we're just looking to double that number, with a view to have 2 in each of our ICS footprints. But it's ultimately to link in with the cultural and strategy and education group to promote the work they're doing around improving our culture. That's how it came out of, but it fell out of the Freedom to Speak Up programme. You're welcome.
Okay. Anyone else? Mark?
Just a couple of questions, actually. And I might have missed it, but I'm not sure I have in the report. And mainly on data. Just we were talking about sickness levels and that. Have your resourcing levels gone up or down over the period of time, last 12, 24 months? So it's good that actually 100% recruitment. So that's really positive. With regards to the reason for the calls, are there any trends analysis? And then equally in that lens, is there anything around repeat calls as well? And then just thinking about the delays, do we track anything about impact to patient health as a result of that? And I hate to ask this question, but I should, is, did any of those delays contribute to fatalities?
Thank you, and I appreciate the questions. So the first one around the numbers of calls, and I think you mentioned initially around ultimately has the headcount increased? Yes, it has. So we are as a trust, we are now around 10% on what our headcount was this time last year. So there's a net improvement, even though we obviously still have people leaving. We're actually retaining more with that reduction, and we're still recruiting. So there is a definite increase. One of the requirements from NHS England for all NHS providers is to ensure that you're in a better position this winter than you were last year. And our projection is that we will be putting out a higher patient facing staff hour level from now right through winter. So that is our ambition. And we have a number of backup plans that if that started to reduce, for example, if we did get a COVID outbreak or some other outbreak that had an impact on staffing, we would be able to enact. So, for example, we can utilise clinical managers like myself who are not in a basic clinical role, but could use that clinical functionality. And also we'll rely on our private ambulance service. So there's a function to increase that, and that's an absolute commitment that the trust have made. With regard to calls and trends, yes, there are. The way that we identify our trends is that when you call 999, you have we call it AMPDS, or it's a priority dispatch system, and there's a code set. So 09, as a clinician, I know them, but there are so 09 is cardiac arrest, 17 is a fall, 32 is an unknown problem, and there are 36 different broad categories. So we can identify the call volume broadly at point of call, and then we can look at it at patient outcome. So there is a way that we can spot those trends and themes. What I can tell you now is that around 20% of our volume is usually falls. It's a really high number, and that's the initiatives that we're doing with the local fire and rescue service to help us access those calls. That's where that initiative came from. Repeat calls, we've now introduced so there are 2 types of repeat calls that we monitor. You'll get a repeat call that could be that a big incident has happened and lots of people are calling in about the same incident. Or you can have what we class as a patient with complex health and care needs that may be calling on a regular basis. We monitor the second part, so those patients who are responding, or where we're responding to it on a regular basis. We do monitor those on a monthly basis with a complex care lead that sits within the control room, and they're a clinician and have a small team that work multi-agency to look at how we can best use. And that could be that we push intelligence out to the community, or it could be that we look to instigate a multi-agency meeting to see how we can best support that patient. And that's done on an individual basis. and we will always, wherever possible, involve the patient in those conversations. There will be circumstances maybe when you don't, but generally we would always encourage the patient to be part of that decision making. The final question around delays and the impact, while it's very difficult to identify if a patient has been harmed due to a delay. However, the NHS is moving to a new safety framework, which is called Patient Safety Incident Framework, or PSIRF. And one of the trends and themes that we've identified this year is around potential harm to patients caused by delay. So I can't categorically say that if we have, and I'll make this up, if there are 10 ambulances queuing outside the L&D and a patient goes into cardiac arrest, it's really difficult for us to roadmap to say that was an absolute cause, because you don't know the etiology of what caused the cardiac arrest. What I can say, though, is that if we have patients, if you look at our performance around our C1 and C2, if that starts to extend out and gets 40, 50, 60 minutes, then I would say that that has a indirect impact on patient harm. If it is per person, generally it's very, very difficult for us to identify that, because there's usually other factors. To answer your final difficult question, has a fatality been caused by a delay? In this area, I'm not aware, but we have had instances where we've declared a serious incident where we believe there was a direct correlation, but it wasn't in this area. But we have had incidents where we've reported that we believe that the delay was the primary cause that could have had an impact on their death.
Quick follow-up to that as well. So that's really helpful to hear. And with the time and effort and the commitment, my questions are anything but just supportive, really, where we are and everything. I'd personally be really interested to see some of that information that comes out, what you find, some of those trends, and how, as a system, we can think about sharing and using that, again, from a perspective of thinking about prevention and what we could do more in that space. And if that was something we could share, I think that would be really useful. Equally to the point of it must be driven by postcode. So there's probably hotspots across Luton where you might be called out to more. So when we're thinking about fuller and place-based working, again, this could be really helpful by way of prevention and what we're looking to do as a whole system and try and take some of that pressure off.
Thank you. Yeah, certainly from the trends and themes, we have because PSIRF is brand new, there are generally going to be quarterly updates. What I'm happy to take back from here is that at a later date, maybe we could, when we have that first generation report, we can look to bring that here and just share it, and we can bring the local patient safety specialist who's, they will probably be much more in the detail than me, that might be able to help you with some of those more local questions that you may have. I'm not sure of the detail, how far it goes down, whether it is down to postcodes, but it will certainly give you trends and themes around certain conditions, and also the recommendations or the actions we've taken to try and reduce that. So there's both sides, but I think I'm certainly happy to bring that back. It probably wouldn't be till the new financial year, but that's something that we can certainly work on and share.
I think that would be great for us to see, and you're coming back to maybe even a point of health and wellbeing board. Again, I make the point, as us as a system, if 20% are down to falls, and that's in a particular area, I do wonder if there's more we could explore and how we support each other in that space. But just as an example, I'd very much welcome if that could come back.
Yeah, because I'm sure as a council we have that sort of data that the trust can use. Is that?
We've got numerous data sets at the moment that we're building, Richard, and in the context of how much we can overlay and sort of identify. We had a community safety partnership today where we're talking about knife crime, and that again just gives us a lens of how we can act as a system. And what I'm thinking about in this context is very much around if there are particular areas in the borough, particular times of year, particular weeks even, where actually more people are called, what's the information behind that and what can we do more of? Falls in particular is something that we're all thinking about as system leaders. So how can we bring the two sides of that, different various elements of that information together and really start to unpack what that means and what we can do.
Yeah, I think that'd be very useful if we could get that moving. Thank you. David.
First of all, just an observation in case any of the other people here tonight haven't come across it. I had the misfortune to be called to a neighbour's not very long ago, where he collapsed. And we had a community first responder attend very quickly. And I have to say that was a fantastic reassurance to people like me who'd been called into the panic. So I think that has potential to become really critically important and good for us as a community. Now, the questions, first of all, I misinterpreted, I think, what you meant by cultural. To me, cultural in a Luton context is we are a multicultural, multiracial community. Now, that brings with it certain things which are just like a reassurance, I suppose. For example, we need to make sure that the staff who are coming with the ambulances or the first responders to the homes of people who've fallen ill do meet the cultural requirements. They speak the appropriate languages. In many types of communities within the town, a man is unacceptable, and it would be better if it was a female first responder who came, or a female member of the crew of the ambulance. So it's all of that language, literature that's given out, translation services, perhaps even using some of the new AI-based instant translation units, which you can buy today. And as I said, the women. So that's question number one. I'll put, it's only 3 questions, so I'll put the 3 and then you can go through them. You talked about the target of arrival to handover, what I think you call A2H. And I think you mentioned a target at Luton and Dunstable around about 30 minutes. I know this is a national issue, but I thought the target we were supposed to be aiming for was 15, which is still a long way off. And then my final one, which is that your report on page 33 talks about vetting by clinicians. What clinicians, what training have they got? What are their skills? Are we happy, or more importantly, are you happy that the clinicians are up to speed in terms of doing that initial triage? So those are my 3 questions, if you don't mind.
Thank you very much. And first of all, I'd just like to say thank you for providing that feedback around the CFR or the community first responder. They do a great job across our patch, and they are very much part of our ambulance family. So thank you. The first part to your question around cultural. So I absolutely hear what you say, and we're often in the ambulance service, we're often in a very privileged position, because generally when we're called and we're entering the premises from any faith, generally it's in an emergency, and all of the staff are educated and trained to respect all cultures and try and deliver that best care. And our response usually to areas, we're very respectful about different religions and different beliefs, and that's very much part of that cultural journey that we're on. Specifically, we know that as East of England Ambulance Service, so if we look at our overall area, we are against the national average around. So if I use the sort of the BAME statistic, we're around just under 5% represented in the organisation across East of England, that is. If you compare that to Luton and Dunstable, we have a very strong, we're 59% representation within the local community. So from that perspective, we work really hard targeting and supporting the local communities, and we want those communities to support us in the long term around providing that future workforce. So that is ongoing, and that's something that's definitely has been extremely positive in this area. With regard to just to reassure the panel members and the chamber members, is that we use a number of translation services. So we do have AI technology on our iPads. Every clinician has an iPad, and they have the ability to utilize an online language. And that is also for people that who can't speak, and they use different methods other than a language barrier. It could be a neurodiverse issue, so we can utilize that AI technology to do that. Or more traditionally, we do use language line if we need to use it in those emergencies. With regards to the arrival to handover, you're quite right, sir, that the national target is 15 minutes. And that is, we would love everyone to be turning our ambulances around within the 15 minutes. You'll see within the report that there's an ambition to not lose more than 1,500 ambulance hours across the trust within a week. We're currently at best, our best hit that we've had is just over 2,500. So we're still a long way off the 1,500 target to improve response times. So we're working with systems to do it in a staggered approach, because this is about hearts and minds as well. So as a clinician and our clinicians on the road, they understand that they need to move out and move on as soon as possible. But when they've built that rapport with the patient, and that handover of care happens, when we hit high pressure points, we're taking a pragmatic approach to start with 30 and then move to 15. But it absolutely is our ambition to get to the 15-minute target. I would be very much doubtful that we'll get anywhere near that this winter. And the final question, sir, you mentioned about the vetting. When we look at our triage, we utilise our highest and our most experienced clinicians within the control room, because to instigate and introduce a hear and treat model, we're asking our clinicians to, in effect, triage patients with their eyes closed and only listen to what they're told. Or when the technology works, they may be able to see the patient. So we utilise in our banding, we have band 7 advanced paramedics, and they are the paramedics that are undertaking that high level of triage. The lower level triage at the call handling point, that is in line with national standards. But from my perspective, where I sit as the acting chief paramedic, I'm very confident that the clinicians, and it's not just paramedics, it's also nurses and other skill sets, mental health practitioners. These are really experienced people who we rely on to deliver that triage, and they've got the experience to do that. So we're satisfied that it's at the right level.
Make one comment, which is just a personal one, which says you're providing the service that we all hope we never need, but certainly I speak for that one incident where it started with first responder and then fully staffed ambulance very quickly thereafter. That's a neighbour of mine who's still there, who wouldn't have been had it not been for your service.
Anyone else? Just a couple of questions, Simon. Follow on about the point about the arrival to handover statistics. The second column is handover to clear. I'm not too sure what that means. Is that after the ambulance has dropped off the patient and then they take a certain amount of time to leave the hospital?
Yes. So that's in effect, that's the measure that is when the crews have discharged their duty of care. The patient is now physically with the hospital or the receiving facility, and they have a 15-minute target to what we class as be green or be ready for the next call. So that's their time in order to get the ambulance or the resources ready and the equipment ready to take the next emergency. So there's a 15-minute arrival to handover, and then there's a further 15 minutes a handover to clear.
Thank you. question about if we go on to the cultural, the culture of the trust. So I think it was your colleague Mark who was here last September and was talking about the CQC action plan and everything that you're intending to do. So according to the report, there's still 35 actions are currently under review and remain on track for completion against their trajectories. And you say that it says that there are areas of concern. Is there any reason why? I mean, is this taking longer than you expected, or are there reasons why it's taking this amount of time?
Thank you. Yes, I mentioned it briefly when we closed off the quality improvement plan, which was the original improvement notices that the CQC served. So the 69 actions that we now have relate to the 9 must-dos and the 7 should-dos, and that's just the terminology that the CQC use. So these are areas that they've identified, and then they're broken down. So they're the headers, and then underneath there's a specific action which makes up the 69. So we're obviously just about 50% complete, and there's still the 35 or the 34 to close. A number of those actions have long-term completion dates. So, for example, introduce and implement the sustainability strategy. That won't be launched until April 2024 at the earliest. So there are markers where we are unlikely to close those actions anytime soon. The areas of concern relate to 2 areas. The first one is the appraisal rate, which we were hoping to have been at 75% by the end of September. We're currently at 64%, and it's obviously nearly December. So that's an area that we're tracking, and we're trying to get back on track. So that's the one area of concern that's within the report. The other area is the fragility around our workforce. So based on some of the questions I was asked earlier around, how will you sort of adapt if patient-facing staff in hours fall, even though we have a plan, there is a finite amount of plan. So if we run out, if people are not returning to work, we're utilising all the clinical, non-clinical managers in a clinical role, and we've utilised and maximised our overtime and our private ambulance provision. There is a risk that our patient-facing hours will stall, and that's because the fragility around the workforce plan is that we need to cover those 800 or those 775 is the number by the end of the financial year. So there is a risk that if we don't deliver the pipeline, that is a potential that could have an impact on patient-facing staff hours. So there, from the Clinical Quality Commission's report, based on what we've put in here around the 2 areas of concern, they are monitored on a weekly basis through the executive leadership team, which is where I sit on. So I appreciate that is more detail that's in this report, but the overall CQC action plan has a monthly update, and then we track the actions that have fallen out overdue. And at the moment, there's only one action that's overdue, which is linked to appraisals. So the trajectory to put that back on track is to be completed by the end of the financial year.
Thank you. I see that 2 conditions have been lifted relating to on how we manage safeguarding and allegation management, which is good news, because I remember Mark coming to us last year and was speaking about the incidence of sexual harassment and bullying within the trust. I think at that point, he was saying the direction of travel was in the right direction. So presumably, does that mean that the culture has improved to the extent that sexual harassment and bullying doesn't take place?
I would say it's improving, not improved. So there's always areas for further improvement. So the first thing around the allegation or the improvement notices lifting, they were specifically around how we dealt with in a reactive way when allegations were raised. So the practice and the policies and the procedures were introduced along with the training of the managers to do so. What we've seen is that we've seen a reduction in cases coming forward, which is a positive because it means that the culture is improving, that people are able to deal with it in a more rapid way. The element around sexual harassment and bullying is that NHS England, along with the Association of Ambulance Chief Executives, have just launched a sexual safety charter, of which we have signed up to as an ambulance service. And we're also running alongside that an empowerment initiative to improve, I suppose, the safety within the workplace, specifically around sexual harassment and misogyny, which is obviously something that should be eradicated from the workplace. And we know that we're not the only industry where this is happening. There are other public establishments that have the same issue. So I wouldn't say it's improved to the point that we need to not start to continue to monitor it. It's definitely improving, and part of that is because people are feeling braver coming either forward to speak out about issues, or what we are finding is that other staff members are being brave to come forward and call out behaviour earlier, which is something that we haven't seen before. So whilst we might always have those extreme cases that we have to deal with through a procedure, what we're finding is some of the low level issues that can continue to manifest and potentially become more serious are being called out earlier. So that is a definite positive for us around how we're dealing with those harassment or sexual harassment in the workplace.
Thank you. It's good to hear. Does anyone else have any other questions? Yeah. Thank you very much, Simon. Appreciate you taking the time to come here. I think as a group, we appreciate that the Trust work is doing their best under very, very difficult circumstances. And to reiterate, it's good to see that the cultural issues are being tackled and appear to be heading in a positive direction. So thank you.
Thank you very much, everyone. Have a good evening. I'll leave you to it.
Okay, we move on to item number 9. Coverage of cancer screening for the population of Luton. So, is that Sally?
Hi, I am on the call, but Chimeme is in the room and she's going to talk to the paper. Thank you.
Okay.
Good evening. I'm Chimeme Obrut. I'm the Public Health Service Manager in Mark and Sally's department. So this is really just an update from last year around cancer screening and the inequalities that we're still seeing. So unfortunately, in Luton, we still have reasonably low uptake in some areas, but we do continue to make progress and to work together to tackle some of those issues. So if I can draw your attention to we are using proxy measures, which is at primary care network level, and using that to see our screening uptake. What we're seeing at the moment shows us that there is variation across individual practice levels, and Table 2 in particularly shows that variation across the different PCN areas. Over the last 6 months, primary care networks have been asked to submit bids to improve their screening uptake. So, and in particularly, it's really encouraging is that not only that we are doing the traditional work that we normally do, but we are following up with non-responders and going much more further to include inclusion health groups, like, for example, homeless people and people that live in deprived area. And that very much is in synergy and links with the areas of the core 20+5 work that we're doing. And we know that in terms of the core 20, just under 25% of that is down to cancer. So it does show that we are, as I said, in synergy with the work that's happening nationally. In terms of the work that we have been doing with our ICB colleagues, in terms of cancer recovery, we are glad to say that our screening programs have fully restored, and particularly around breast screening, bowel screening, and cervical screening as well. Some of the actions that we've been doing to see that includes around sort of public awareness work that we're doing, working with our PCNs, as I've just talked around, non-responders, some community engagement work, which sits in public health specifically. And of course, there is NHS England are looking at putting a screening mobile unit in Luton, and that we're looking forward to seeing that happen. In addition to that, we have given supplementary funds to primary care networks to help them get their screening uptake more. And what's interesting and potentially exciting is, of course, that we are part of a national cervical screening self-sampling study, which is being run by the Department of Health and Social Care. And that research study is happening now with, I think it's Lee Vale. So our next steps moving on from that, is to continue our focus, encourage primary care networks to get the screening uptake, specifically around learning development and autism patients. In addition to that, we want to enable risk stratification and prioritisation around cervical screening patients who have been overdue for their own screening. As I said, we are supporting practices, and we've enabled them with some funds, and we are going to now be implementing a new cervical screening management system in Q4 of 23 and 24. And finally, one of our big efforts will be to look at data collection with our public health colleagues, particularly around including ethnicity and deprivation, so we can do a bit more targeted interventions. So that's our update.
Thank you. Does anyone have any questions? Yeah. Councillor Bright.
Thank you. Yes, the screening programs that you have, I'm just curious, especially as a new councillor to this this particular thing. Why do we not screen for prostate cancer? Because we've got that, it's quite female centric. I know we've got the lung cancer coming in, and we've got the bowel cancer, but breast cancer, yes, brilliant, cervical, but why not prostate as well?
So firstly, prostate cancer isn't a national screening programme, and part of the big reason for that is because of some of the false positives that we get. So at the moment, it hasn't been established as a national screening programme because of that. However, we are doing a find and treat piece of work around it, and we are promoting and encouraging men to come, particularly where there's a higher risk, so mainly our Black African and Black Caribbean men, and the age rate around that is a little bit younger. We're targeting those younger years. So we are doing it, but it isn't part of a national screening programme.
Okay, thank you. It does seem rather a shame, doesn't it? Because even a false positive doesn't matter if it's catching the ones that aren't our true positives. I think it's something that's important. All right, thank you very much.
I don't know if Sally wants to come in a bit more around that, the prostate stuff.
Yeah, I'm happy to. For a screening programme to become a national screening programme, there's a lot of evidence base that needs to be put into place. So sort of years of randomised controlled trial type studies and work. And it goes through a very rigorous process through the National Screening Committee just to make sure and be really, really robust that the benefits outweigh the harms. So the harms would be through people being told that they had or are at risk of cancer, and that if there's more cases of that than there are of actually cancer identified or cancer missed, it's really critical weighing up those negatives versus positives. And also if cancer is identified but actually would have been there already and not caused a problem, and that person would have just sort of lived a happy life but with cancer in the background, then that obviously this sort of false it creates a lot of anxiety. So all of this, it's a very tricky balance with a screening program. So there needs to be really, really robust evidence base. And the lung cancer screening is just now being worked through as being one that has been approved and is starting to be rolled out as a pilot. And that's through years and years of work around, do the benefits outweigh the harms that might be caused by having that and giving that unnecessary anxiety to people. So that's been worked through and is now being rolled out slowly across the country. And I think prostate is one that keeps getting come back to and keeps getting reviewed about those, do the benefits outweigh the harms. So there's these kind of find and treat pilots that are being rolled out now, but they're not screening, they're not national screening programs, but they're trying to identify higher risk people and seeing if that is a good way of doing it. So it's a very complicated kind of, to have a national screening program on something, there has to be a lot of robust evidence base in place.
Okay, thank you for clarifying that. Hopefully that will change things. I know there's been some quite big innovations with prostate cancer diagnosis recently, so hopefully it will change soon.
And that's the other thing with the national screening programs and committee, they go back and re-review the evidence base and look again once new procedures come into place or new processes or new testing methods. So it's not there's always a call to re-review the evidence base on a screening program and come back, and which is why the lung cancer one is now come through. So it may well be that prostate at some point in the future becomes a national screening program, but we're not at that point at the moment.
Thank you, but at least we're encouraging it. That's the main thing.
Yeah. And sorry, just one more point. I always do this. My brain whirs and I think about one more point after I've finished talking, so apologies. But with prostate cancer, the other thing with that one specifically is that often people will have prostate cancer, but it's not something that they die from. So if it's identified and that it would have actually kind of run its natural course, then it's that point that I made earlier around what is the benefit of then identifying it if actually would have been kind of okay in the background, but you've just identified it way earlier and the treatment process doesn't change. So prostate cancer is one of those ones that people tend to have for longer, but not cause mortality necessarily. But it's a tricky balance with prostate cancer specifically on that point. Thanks.
Anyone else? Yeah, Councillor Rowley.
Thank you. I have a question and a comment. So firstly, the supplementary funds for the PCN, is that from NHS England? Or if you could just tell me a little bit more about that, because I know there's a point about the last 6 months they've been submitting bids. And secondly, I'm just looking at the different PCNs and the percentages and how some are significantly lower for some uptake and others. And there's a handy little grid on another report with the different PCNs and which practices are part of them. Has there been any sort of looking into the areas that these PCNs are within? I think what I'm trying to get at is, I know you're saying the next steps are to look at the encompassing ethnicity and deprivation. Is there, and actually most minority ethnic populations, things like cervical cancer screening, breast cancer screening, bowel cancer screening are quite taboo, and there can be language barriers and things like that. So I'm wondering if it's more so not PCN specific but area specific, and the PCNs go across so many different areas. I just feel like it would be useful to have a bit more data on maybe at ward, I don't know if this is like not possible, but at ward level, what the screening uptake is like, and if that's being looked at, basically.
Yeah, so as part of the cancer outcomes project, we did look at deprivation and PCN and uptake across the different cancers screening, and where we have seen cancer in those PCN areas. And it was not presented here, but we can certainly start building up, and that's part of that whole data piece. It's better to bring something that's a bit more robust than just talking about the deprivation, although we do have some of that information available. It's just not presented here. So certainly can go back and give you some of that, but with caveats, I think, so that we have the fuller picture. And I can't remember the first question or statement that you said.
Yeah, it's about the supplementary funds for the PCN.
Oh yes, I think that's from NHSE. I'm looking at Sally. Is this it comes from the ICB funds, but I think it comes down directly from NHS England, which is government. Supplementary funds for PCNs.
Yeah, I think it's ICB funding that gets passported across to the PCNs. So yeah, I think it's NHS, ICB, PCN. I think that's the flow of it. I just actually had my hand up because I just wanted to come back in on your other point, which was around ethnicity specifically. So and sort of cultural acceptability, which I think is a really important point, and is building into the work of the Cancer Connectors that Chimeme mentioned that are within the public health team. So we've knowing that there can be some taboo and sort of cultural barriers around some of this, and that particular ethnic groups or cultural groups have lower, not necessarily just lower screening uptake, but poorer cancer outcomes overall. And we can kind of extrapolate national data to be able to help us with that picture. We've got particular community groups that are represented through the Cancer Connectors to work with specific communities around some of those sort of stigma issues, and understanding the processes and where to access services, and helping kind of start the conversations about cancer in a culturally sensitive way. So I don't know, Chimeme, if you wanted to come in on those roles a bit more.
Sure, yes. Got to mention those. So there are 3 connectors with a project manager and a senior manager. So we've got a particular person who does South Asians, and when I say South Asian, it is across, there's no very specific, and her workload is working to try and get the different groups that exist within that non-homogenous group of South Asians, so Bangladesh folk and other folk. And then we have somebody who represents our Eastern European, and again, understanding that they're non-homogenous, so we want to go to Romanians and Polish, and they go out and they speak with communities and use the venues and the connections and assets that they have already. And then we have somebody who does Black African and Black Caribbean, all because, as Sally has said, those poorer health cancer outcomes. So we do have them, they're out and about, and they can feature again in a future report if you're interested to know about them. They are a 3-year project with their they are funded by Macmillan, and they sit in the public health team.
Thank you. Now, I think that would be useful just to know a bit more about that, because that's what I was getting from the report about the deprivation and also the ethnicity and things like that. Thank you.
Thank you. Maybe the table on table 2, the information is from 21-22, but the cancer recovery position is presumably that is the position as now. But, excuse me. So is it possible that these numbers have been improved in table 2 since then?
Yes, it is possible. I don't have the detail. That would be Kathy, who would have the detail on this particular issue. But certainly, I would hope they've improved. I can't really answer that in a solid way, so I can definitely go away and find out a bit more about it, Chair.
Yep, that would be useful. Thank you. Councillor Ambia.
Thank you, Chair. I'm referring to page 36, point number 11. You have mentioned about one Luton practice is taking part in the national cervical screening sampling. It will be helpful if we know any other name of the practice, or is it only for the participant, only for the specific people who are registered in a particular practice, or is it for the across the town? Anybody can participate for the sampling. and it will be helpful if clarify the location and name of the practice.
So that
Then we can maybe ask for people to give some sample. Yeah, this is my questions.
so that's Lee Val practice that's taking part in that. I'm not sure if there are wider opportunities for others, but it's actually Lee Val, and I can go back and find out if that's open to others. But it's Lee Val that's taking part in that.
It will be useful if it is get circulated to the community or make more awareness than people who are like maybe symptoms, who have maybe some sort of other practice. They can refer to their patient to the leave veil. So be helpful. And also another thing is you have mentioned under the point number 11, community engagement to address barriers. But you didn't mention about which type of engagement. Is it are you referring to the well-being event you will promote, because you do few well-being event across the town? So it will be, if you can specify the exact event or something, then we can encourage people to attend and get more information from the engagement. Thank you.
So the Cancer Community Connectors, what they're really good at doing is going to where people are and doing these engagement events. So we might have them at a counsellor surgery session, we might have them at a mosque or a church, we might have a very specific health and wellbeing event where we invite people. So it's a variety of different ways of engaging with the communities that they are focused on, and we tend to give flyers out and tell people if we want to do something, talking to people. If there's an event happening, then we'll ask to maybe piggyback on it. It might not have anything to do with health, but we know it's going to hit one of those target groups. We'll go on the back of them. So they are working their way around and trying to get us their presence known in the community as much as possible.
Thank you. Just one more question, if you don't mind. What is code 20 plus LUS5? It will be not sure what is the meaning.
Yes. So NHS England have, because of COVID and because of the inequalities, we've seen the inequalities that exist because post-COVID, have to tackle that inequalities. One of the things they've done is put together a program called Core 20 plus 5. And what that means is we're looking at the 20 most deprived areas in specific areas across 5 clinical areas. So one of those clinical areas is cancer, one of them's hypertension, one of them's mental health, and I can't remember the other 2. Sally's looking at me.
Respiratory. Cardiovascular disease, and I think maternity is in there as well.
Coronary heart disease.
Yeah.
Coronary heart disease or coronary vascular disease. So those are the 5 clinical areas, and cancer is one of them because of the impact of, COVID and the inequalities experience.
Thank you. Thank you, Shimomi. Thank you, Sally. We're asked to note the reports and support the screening uptake action plan, which I think we can do. Okay, thank you. We go on to item number 10, the draft work programme. If anyone has any questions or comments about that, Councillor Wynne.
Just to pick up, just to make sure it doesn't get lost, I think I made down a note that I saw nothing in your future programme relating to dental services and accessibility, but I think you should have already, I think we've already picked that one up.
Yeah, noted.
The only other thing that was obvious to me looking at the programme was there doesn't seem to be anything addressing what I see as being the holistic approach to health and social care. So if I give you an example of what I mean, Chair. It linking back to schools and education, food choices, how to cook, understanding of obesity and the issues that it's going to cause, nutrition and vitamins and minerals and the effect of those on health, the role of exercise, the understanding of what I suppose to some people is obvious but not to others, that you can't tackle obesity just by worrying about what exercise people take, because no matter what exercise you do, it doesn't actually fix the problems in the kitchen. So I suppose I looked at the programme as a newbie. I looked at the programme and I couldn't see anything that was talking about an holistic approach.
Okay, so I think a lot of what you've been talking about, some of that falls under the remit of the Health and Wellbeing Board. Talking about obesity, we have a healthy weight strategy report due on the 27th of February. And your point about dentistry is noted. Thank you. Sorry, Sally, you had your hand up?
Yeah, no, that's fine. Thank you. I think you just covered mostly what I was going to say, was just that the healthy weight strategy is quite broad and encompassing, and covers access to food, access to physical activity. So all of the threads that encompass healthy weight. So as you just said, it's not just about exercise, it is about eating and access to healthy eating and access to understanding about how to eat healthily and all of those elements. So we're trying to bring it all together under the food plan and food strategy, the physical activity strategy, and various bits, and have a whole kind of all-encompassing healthy weight program of work. So that's coming through in February.
Thank you.
Thank you, Sally. I just find that very often when you see anything appearing in the press or on the TV and so on, it's all very focused on one area rather than thinking about the overall requirements.
Yeah.
Okay, that's
just the maternity pathways and women from Black populations dying during childbirth. Do we potentially have a date as to when that may come to us?
Sally, that's not your...
So it's not specifically my area, but I know there is a lot. So it's one of the core 20+5 key areas as well, the maternity services. And I know there's a lot of working with Luton Dunstable around maternity services at the moment, but I can take it away and find out when something could come through, particularly so maternity outcomes and ethnicity. Is that what you're asking for specifically?
Yeah, it's just in the to come section on the thing, and I remember we brought it up last year. But
yeah, I think it is important, and it's still a really pertinent issue. So I can take that away and follow up. It'll be Sarah Stanley in the ICB that I'll pick that up with, but I'll come back to the chair.
Thank you. Yeah, that's been imminent for a few meetings now, isn't it? Yeah, so that would be good. Thank you. Councillor Ambia.
For work program for next two meetings, is there any chance we can review, Sally, about vitamins campaigns? Because what we're seeing is in our community, adult and children, they have a low vitamin deficiency, vitamin D deficiency, and other vitamins because of the our culture and habit and weather. Is there anything we can consider on the work program awareness about healthy eating to reduce the vitamin D deficiency and other B12 and iron deficiency, to make an awareness to the public, how to tackle those things for healthy eating, because it's a common issue, what we've seen from my personal experience.
So healthy eating will be picked up through the healthy weight activity that we mentioned previously. Vitamin D isn't something that we picked up specifically to focus on within that around sort of vitamin uptake specifically, although we do also then have the healthy Start programme, which is partly it's about food vouchers and vitamin supply in for newborn babies and mums as part of the Healthy Start programme. So we can update on that more broadly, but I think it's probably best just bringing it through as part of the Healthy Weight piece of work around the food plans.
So I think that's acceptable. Yep, I think.
Yeah, acceptable.
Thank you.
That another thing is you have mentioned about children who are on the like the under the poverty, like under food they are like people who are relying on the like benefits. Of course, is there anything we can give the free vitamin D supplement through this work program, through the schools, or kind of things, or voucher people who are on the low income?
So Healthy Start vitamins are sort of more or less that, but not for school age, for infants. It's a national programme. We've been doing a lot of work to increase uptake on that recently. So I can bring an update on the Healthy Start programme as a separate point, if that's helpful.
Thank you, Sally. Thank you. Okay.